Hello, everyone, and welcome to this session. We are speaking with Stephanie Nix, a genetic counselor with Levine Cancer Institute, and we're focusing today on genetic counseling and breast cancer. This video is brought to you by Carolina Breast Friends and Nothing Pink. Thank you for being here with us today, Stephanie.
Thank you for having me.
Yes.
So what we're going to be doing today actually is focusing on some hot topics and submitted questions. We have other videos on the site that are saved that will give you some background information about what genetic counseling, genetic testing, and how we use genetic results for care. But instead, this is a little different. We're doing some questions that have been submitted by members. All right, so for our first question, and this comes up very frequently, particularly when we have done genetic testing and we've identified a mutation in someone who has children. Often their first concern is, what about my children? So question one, what age should genetic testing be considered when a mutation has been found in a relative? And in many cases, we're talking about a parent. So if a parent has been identified to have a mutation in a cancer risk-related gene, their child would have a 50% chance to have that same genetic change. So the general guidelines say that we are not to test children under age 18 for adult onset conditions. Although it is appropriate to do genetic testing or what we call family variant testing when there are medical management recommendations that can be made in childhood. My only caution with this is sometimes parents will come to us and their child is turning 18 very soon, and the parent is very anxious to get this testing done, particularly if their child is going away to college. They may personally feel like that they are ready for the information, but we really want to consider more factors in the decision making for that young adult. So number one would be their own ability to understand and consent personally for that testing. So it's not the parents testing, it is that young adult's testing. They need to be able to take into account what that result could mean to them and be sure that they're ready. Also, what's their family or their social situation? Consider that many young adults in that 18 to 22 range are just starting out their life. Maybe they're going to, post high school education. Maybe they're starting new jobs. Maybe they're getting married. They might be under a lot of stress because of those changes. So we want to consider the timing of when we do that testing and what's going on in their life. Also, what's the timing for when we would even begin high-risk screening for whatever genetic variant is identified in the family member? Does that screening begin at age 20? Does it begin at age 25? That type of thing. The next would be the question about insurance and life insurance. And that's a complicated discussion, but we like to have that with young adults. And then also considering what the impact on their reproductive choices, risks, and decision-making that could come from that. So most definitely, when someone has teenagers or young adults who have not been tested, and we're trying to figure out how we approach that conversation with them, we want to introduce the family history and make them aware that there is a potential risk to them, but also provide enough space for the young adults to be able to choose when and if they even want to do genetic testing. We have other ways around if it turned out that someone did not want to have testing and we wanted to use the family history information instead for screening. So that's a great question and a very common one that we hear. All right, question two. I get this quite frequently as well. Someone may contact us and say, I really would like to do genetic testing because I have a relative who has some type of cancer. And my question here started focusing on the idea of, if I have testing and it's negative and I'm still concerned about my family history, what do I do? But to answer that, we really have to back up even further and think, how do we approach a family history of cancer? So if it ever possible, when there is a family member that has some type of cancer, and particularly those that meet our testing criteria, so young age of onset of breast cancer, colon cancer, ovarian, pancreatic, metastatic prostate cancer, that type of thing, we want to start our testing discussion with the person that has that cancer. If it is all possible, they would be the ideal person to do testing. We understand that that's not always possible. It may be that they had testing and we don't have access to those records. So let's say step 2, if there has been no testing, or we cannot obtain records, or testing was done and there was no family variant that was identified, then our next step would be testing the person who is presenting to us for discussion. Okay. Now, if that individual who has the family history tests positive, then we have specific guidelines that we want to follow based on what those genetic results are. So whether that be for extra screening, earlier age to begin screening, or specific types of screening we wouldn't normally do otherwise. If they test negative, so if in this case we have someone who does not have cancer, who has genetic testing, and the testing is normal, nothing has been identified, then at that point, specifically for breast cancer, we have a risk model that is available to us, and it's called a Tyrer-Cuzick for the individuals who designed the model. And this model will take into account family history along with other personal medical factors to estimate what the lifetime risk of breast cancer is. So some of the factors that are included on this risk model would be our height and weight, our breast density, whether we have had a pregnancy before, what age of first pregnancy, also if we've ever had a previous breast biopsy and what the pathology was on that breast biopsy. And then again, the family history information, particularly for female relatives and those that have had breast cancer and what their age of onset was. So in this case, genetic testing can be negative, and we still have a concern about the family history. In that case, for breast cancer, we can run this risk model. And if a person has a risk greater than 20%, then they can have a discussion with their provider or a high-risk specialist about other options for breast cancer screening. So they may qualify for high-risk screening. Okay. Now let's back up to the very beginning here, and let's say that someone presents to us because they have a family history of breast cancer, and they speak to their relative after our appointment and learn that that family member already had comprehensive genetic testing. In that case, as long as, and I'll hit this on another question later, but generally speaking, no genetic testing would be recommended for that relative because the person who had that breast cancer has already had normal genetic testing. In that case, we again run the Tyrer-Cuzick model to estimate the lifetime risk of breast cancer and determine if they qualify for high-risk screening. So we never ignore the family history, even if genetic testing is normal. We always want to take that into account. Question 3, genetic testing is constantly changing, as well as our interpretation of genetic variants and what the National Comprehensive Cancer Network considers for recommendations for screening and criteria for testing. So I wanted to highlight just a few of the changes that have occurred with those criteria in the last year or two. So one of the major ones is that the age of breast cancer diagnosis has been revised from age 50 or from 40 to 45 to 50. So now if we have an individual who has breast cancer at age 50, then they qualify for genetic testing, even if they have no other family history of cancer. So we've been able to add that extra 5 years onto our age criteria. All ages of triple negative breast cancer now qualify for genetic testing. So that's an improvement and expansion in the criteria. We also can do genetic testing for breast cancer in the setting of metastatic cancer, and that's mainly to determine if there's any systemic treatment options like PARP inhibitors that can be offered. Also, the same thing for HER2 negative breast cancer. So that alone would qualify the individual for genetic testing. For colon cancer, we have some recommendations for testing that are still under age 50 for an individual that has colon cancer, but we can consider genetic testing beyond age 50 depending on the personal or family history. So it's a little expansion there as well. So the bottom line is that more individuals are now meeting criteria for genetic testing, but we do not have a recommendation yet or an adoption of universal cancer screening at this point. So our recommendation would be, if you have questions or concerns about your family history, speak to your primary care doctor, speak to your OBGYN, or reach out to us and we can set up an appointment and review that information with you. So as far as specific gene updates, the NBN gene is no longer considered a cancer risk gene. And on the other end of that spectrum, there are two genes called RAD51C and RAD51D that we previously had classified as having insufficient evidence on breast cancer risk. And now we have a change in the guidelines that if someone carries a genetic mutation in one of those two genes, then they're recommended to have an annual breast MRI. So in our office, we have been reaching back out to patients that we know have had a gene mutation in one of those two to try to get them back in contact with providers so we can get them started on any screening. But we would recommend anyone who knows they have previously had that genetic testing to reach out to us.
Sure. Can I ask a question, Stephanie?
Yes.
So are there other entities like I believe it was the College of Breast Surgeons or something along those lines that had other recommendations for genetic testing that would lead for patients to receive testing outside of these that were listed here?
Yeah. So that's a really good question. We all use the NCCN criteria to determine if somebody qualifies for testing. So that's one part. That's our first reference. Sometimes for the type of cancer that we are encountering, there is not a specific criteria. And in that case, we can go and look at smaller or cancer specific specialty groups, and they may have published a recommendation that is different or supplemental to NCCN. So, there's other ways around it. And obviously, if we're talking about insurance criteria, many insurances have their own criteria as well that may not align with our NCCN criteria. On another spectrum of this question would be this idea of universal genetic testing for breast cancer. So that's been discussed, but it has not yet been adopted. So we'll see what happens with that in the future. So our job as counselors, when we evaluate a family history or personal history, is to look at all of these different factors and determine, what the recommendation would be for genetic testing. And then if a person does not actually meet criteria and they still would like to do testing, talk through with them the self-pay options that are available. All right, so I mentioned this briefly with one of the earlier questions. And this is going to require looking at the family tree, which we call a pedigree over on the right. So question 4, if I had genetic testing for a familial BRCA mutation, and assuming that was negative, should I consider a larger panel? So to explain what that means, Historically, BRCA1 and BRCA2 were the only genes available for genetic testing for breast cancer. That's expanded well beyond that, and many of our largest panels now are testing for 84 cancer predisposition genes, covering more than just breast cancer, breast, ovarian, colon, on and on. So let's say that if we look at a picture of the family tree on the right, consider first individual number 1. So her mother has had a diagnosis of breast cancer at age 42. She's currently age 55. Her mother was identified to have a pathogenic BRCA1 variant. And so what this means is that her children, in this picture with the number 1 and the number 2, they each have a 50% chance to also carry that genetic variant. And if they tested positive, then they would be eligible for high-risk screening and discussion of preventative care. So when we look at this family history, then the question that we as counselors have is that sufficient? What if we just test that person, person number 1, for the BRCA variant? And the answer is it's not sufficient with this particular family history. So it's very important to take into account the entire family history. So in this case, if we see someone for family variant testing, a variant has been identified, a pathogenic or a mutation has been identified in a parent, we need to take the information for the opposite parent to make sure that we understand if they have anything that would indicate additional testing. So in this case, if person number 1 and person number 2 both have genetic testing that is negative for the BRCA1 variant that their mother has, it is not sufficient because their father's sister had a diagnosis of ovarian cancer and no genetic testing had been previously performed. So in this case, we actually would be able to offer person 1 and person 2 a panel, a larger panel, or they could do family variant testing and then at some point follow up and do a larger panel to assess the family history. Now, alternatively, those 2 individuals' father, person number 3 on our pedigree, could be tested. And if he tested negative, then neither of his children would need to have testing for any cancer risk genes based on his family history. So I often think of this as a gatekeeper. So if the parent tests negative, then their children do not need to be tested. Okay. So another layer of question on this is, what if our paternal aunt had ovarian cancer age 60 and she had BRCA1 and 2 testing that was negative? Is that sufficient? Well, technically, there are other genes beyond BRCA1 and 2 that genetic testing would be recommended to include. And so if that individual is living, then we would recommend that they have additional testing, so a larger panel to be offered. And then the ringer in the picture that we haven't talked about yet is that we have a paternal grandfather that had colon cancer at age 40, and that also by itself meets criteria for genetic testing. So bottom line here is that it very much depends on the entire family history, what testing was done in the affected relatives, if anything, and if at all possible, we like to get medical records of those genetic testing results in the family so we can really help decide if any additional testing is needed. All right, question 5. This is related to the difference between genetic testing that we think of and tumor testing. And so you'll often see tumor testing be referred to as somatic testing. There are multiple different tumor-specific type tests, and some names that you may come across would be Caris or Foundation One or Tempus. So these are laboratories that are doing analysis of tumor tissue specifically to look for genetic mutations in those tumor samples. So every cancer has many different somatic mutations, and typically they are isolated just to the tumor. If someone has tumor testing and a gene mutation is identified, the follow-up for that would be to offer germline testing, which is another way to call the genetic testing that we all refer to. So that's taking a sample of blood or saliva to analyze the DNA that we were born with. So tumor results are not a representation of the person's entire genetic material. Sometimes those tests can indicate that a change in a gene in a tumor is likely to be germline, but still we need to follow up with additional testing for that. This has come up for us where we might have a person who presents for discussion of a family history of a gene mutation, and then we learn through records that that family member actually only had tumor testing and never had somatic and never had germline testing. And so again, even in the person who has cancer, if their tumor identifies a mutation, it does not mean it is actually in that person's DNA that could be inherited by relatives. So follow-up testing again for the person that had that original testing, or discussion of the whole family history for the person who's presenting for discussion. So it's definitely a nuance, and there are many different types of these tests that are available, and they're often used to determine if a person qualifies for a clinical trial or a specific type of treatment for their cancer. All right, another common question that we get is, what about direct-to-consumer testing? What is this? Should I do it? What does it mean? Sometimes people will come to see us and they have already had some type of at-home genetic testing, and they're wondering if that testing is enough. Did it cover everything I need to? So there's actually two different categories of this. The first is the type of testing that's called direct to consumer. And think about that as like your ancestry DNA types of tests. You order a kit yourself, you pay for it, it's delivered to your home, you spit in a tube, and then it sends off to a laboratory, and then you're going to get a report in a few weeks that give you some information. So this type of testing is looking at the DNA, but it's looking at small fragments of DNA that may be associated with a health condition or a feature of our, it's something like blood pressure or whatnot. And so they are giving a lot of times results that are likelihoods, not positive or negative. So it may come back and say, based on your DNA profile, your likelihood of diabetes is 2 times what it would be if you had a different genetic profile. But keep in mind, you always have to consider what the background risk of something is. It may be that your risk for that condition is 1% in your lifetime, and a 2 times increased risk takes you to 2%. So you have to consider the whole picture on those. So this type of testing, even if results are quote normal, it does not rule out the chance of someone having whatever that disease is. And many of these that include cancer type results, they may not even be looking at most genes that we know we would test clinically, or they may only look at a certain number of mutations. And so it's not a replacement for genetic testing that we offer clinically. Now, the other version of this would be consumer-directed testing. So this would be tests that are, they are clinically oriented, and they're directed to the consumer to reach out to that laboratory or business, for example, but they require a healthcare professional to sign a test requisition. So Color, Semaphore, Veritas, those would be examples. So they may actually use full gene sequencing. They may provide information about genes that can be used in a healthcare setting. Mutations could show an actual increased risk. Inconclusive or variants of uncertain significance are still possible. So even those results need to be interpreted by someone who is familiar with what those types of DNA results can indicate. So when someone is choosing this question of direct to consumer versus consumer directed testing, consider what am I trying to achieve? Does this test actually answer a question that I'm looking for? What's the accuracy? Is the test reliable? How will my personal information be protected? How will I receive the results? Will a trained professional report them to me? Will I receive a copy of the results? How will I, know if something is wrong? What happens if new information is discovered? Will that laboratory reach out to me and provide me an update on my genetic testing? Some of those of you who have had genetic testing before may know that when we encounter a change in a gene that's not yet been classified as positive or negative, the laboratory will designate that as a variant of uncertain significance. And they have a protocol in place that those variants of uncertain significance are evaluated. And if new information is learned, then the laboratories will typically send an updated report to the person that ordered the original testing. And if that result now has some sort of an upgrade in interpretation, then that provider should reach out to you and give you some information on what that means. So a laboratory that we choose has a process for that in place. All right, and I thought this was an interesting question. It made me wonder sort of what somebody may have read online or seen in marketing materials. So what is whole genome sequencing and can it help me? So whole genome is, think about that as all of your DNA. So it's your entire 20 to 30,000 gene sequence. And that's very different than what we do for typical cancer genetic testing. So the types of tests that we order are called targeted panels. And we're looking at a predetermined section of DNA genes to see if there is a mutation in that gene. So a mutation could be a piece that's extra, a piece that's missing, or a typo in the gene sequence that makes that gene not function correctly. So it's very targeted. When we do cancer testing, we're looking at cancer genes. Whole genome sequencing generates a massive amount of data that has to be analyzed and interpreted. It's very expensive. It's not a replacement for current testing that we're using. Often how whole genome sequencing may be used would be either in a clinical genetic setting, particularly thinking about maybe individuals who are looking for a diagnosis in maybe a child that has some complex medical problems. And so whole genome sequencing may be available to help do that, to find rare genetic syndromes, or even to research the genes that may be related to common disease like diabetes, high cholesterol, depression. So that's in the research setting. So it definitely is a method or a technique that's very helpful for discovery in the research setting and even in a clinical setting, but we're not using that as a routine type of test for cancer genetics. A really good question. I think that comes to the end of the questions that we had that were submitted. So below is my information. If you have a question about your personal history, about genetic testing, if you'd like to have an appointment at Atrium Health Levine Cancer Institute. I can be reached by email or by phone. Our genetic counseling visits are free, and they are available by phone visit or by in-person visit. Alternatively, if somebody does not live in this area and they're interested in having an appointment with a genetic counselor, or we have relatives that live outside of this area who want to talk to somebody about genetic testing, particularly if there's a variant that's been identified in the family, then there is a way to search based on your address on this website, www.nsgc.org. And I thank you all for your attention, and very much appreciate being invited to speak.
Thank you so much for your time and information, Stephanie. This was so valuable. We look forward to sharing this.